So today we will talk about antenatal assessment of fetal well-being. This topic will assess or will talk about the assessment in the second half of pregnancy. There is a separate lecture for the fetal assessment in the first half of pregnancy. Uh, Prenatal care is designed to ensure the well-being of both the mother and the fetus. Aims of this is to identify fetuses at risk of intrauterine hypoxia so that we can interfere with any pregnancy that that is at risk of permanent injury or death for the baby, plus to identify the pregnancies that are not at risk of intrauterine hypoxia or death, so we will avoid any unnecessary intervention. Uh, Conditions placing the fetus at risk of intrauterine hypoxia, so that we should do these types of fetal assessment: hypertensive disorders, DM, chronic renal disease, thrombophilia, postnatal and post-term pregnancy, fetal growth restriction. First of all is the fetal movement counting. Fetal movement decreased for several days and stopped completely 24 to 48 hours prior to fetal demise. This not happen to all pregnancies. About 50% of intrauterine fetal death is preceded by reduced fetal movement. Um, 10 movements in 24 hours is something reassuring. We use the kick charts during non-stress test to make the pregnant woman counts the number of fetal movements. Advantages is cheap. It is used as a primary screening test, not something diagnostic. I mean, if the fetal movement is not good, this doesn't mean that the baby should be at risk of hypoxia. The good aspect of the fetal movement that if it is good, the hypoxia will be very unlikely. Disadvantages: if used alone, it may lead to unnecessary interventions, early induction of labor, hospital admissions, increased risk of interventions, other interventions like maybe cesarean section. Stillbirth continue to occur with patients failing to report absence of noticeable fetal movement. Symphysis fundal height, single measurement is not that good. Serial measurements are more effective than a single. After 24 weeks has been taken to be equal in centimeters to the weeks of gestation, plus minus 2, up to 36 weeks. And after 36 weeks, the margin of error could be 3 centimeters. Reduced symphysis fundal height measurements correctly identify only 25 to 50% of fetuses whose birth weight was less than the 10th centile. In other words, more than 50% of small 4 dates will have normal symphysis fundal height. And this is because the margin of error, we have a margin of error of 2 centimeters, 2 weeks here. We have some other specific tests. One is called the non-stress test or the cardiotocogram. Cardiotocogram, if it is done intrapartum, because we have a uterine activity, toco means uterine activity, cardio means the fetal heart. Antenatal CTG, اللي هو non-stress test, employs external or indirect methods of monitoring of fetal heart rate. This is the cardiotocogram. The upper one is the fetal heart. The lower one is the uterine activity. Four variables of the CTG can be assessed: the baseline, the variability, the accelerations, and the decelerations. All four variables are affected by oxygen deficiency, making it a useful tool for diagnosis of antepartum fetal hypoxia. Um, Cardiac activity in general is controlled by the sympathetic and parasympathetic nervous system of the fetus. Um, the sympathetic will increase or accelerate the fetal heart, and the parasympathetic will do the opposite. The fetal nervous system matures between 28 to 32 weeks gestation. So before 28 weeks, CTG is relatively featureless, and it shouldn't be done. Uh, it will have a high baseline fetal heart rate with reduced variability. With advancing gestation, fetal heart rate slows down, means the baseline will slows down and the variability will increase. After 28 weeks, fetus develops cycle of quiet, active sleep lasting for 60 to 70 minutes. This usually lasts for 20 to 30 minutes and characterized by absence of fetal movements and absence of acceleration and low variability. Normal baselines between 110 and 150. In preterms, it could be up to it, it can be accepted up to 160. Variability is a variation of heart rate in successive beats. 5 to 25 is normal. Less than 5 is considered as poor variability. Poor variability can happen during hypoxia, during sleep cycles, in preterm babies, in some maternal drug like pethidine, diazepam, and local anesthetics. If the variability is reduced with recurrent decelerations, this is a sign of intrauterine hypoxia, and it should be taken seriously, because in uh, sleep phases and prematurity with maternal drugs, we shouldn't have decelerations. So decelerations with a poor variability, this happened only during hypoxia. Acceleration is increase in the fetal heart rate of more than 15 beats per minute for more than 15 seconds. It is associated with fetal movements, external stimuli, or uterine contractions. Loss of acceleration is the first sign of hypoxia, but also it could be due to sleep cycle. So not all CTGs with no acceleration presents hypoxia. Deceleration is the opposite of acceleration, is a drop in fetal heart rate of more than 15 beats per minute for more than 15 seconds. It is a sign of hypoxia, but also associated with maternal supine hypotension. Um, um, if the deceleration is isolated, means just single one, not recurrent, it has a little clinical significance, while recurrent decelerations, especially if in the absence of uterine activity or with loss of variability, is always a sign of hypoxia, and it has a poor prognosis. The criteria for the reactive CTG is the following: heart rate between 110 and 150, variability more than 5, 2 accelerations in 30 minutes, and no deceleration. First step or first sign of hypoxia regarding the cardiotochogram is the absence of acceleration, followed by loss of beat-to-beat variability, and the appearance of deceleration, and finally bradycardia. This is a normal baseline, which is about 150 uterine activity, as you can see. This is a fetal tachycardia with poor variability. شوف ال baseline is 180, which is abnormal. This is called sinus fetal tachycardia. This is the fetal bradycardia. Baseline is around 60, between 60 and 70, or between 60 and 80, which is abnormal. This represents a good variability. You can notice that we have changes in successive beats in the baseline. Um, uh, okay. The lower CTG presents the reactive CTG. We have the accelerations, we have good variability, we have no decelerations, and we have a normal baseline. This is an example of a CTG with poor variability. This represents again a good CTG. If we consider this as a deceleration, you can see that isolated deceleration is of no clinical significance. So the trace after the deceleration is an example of the reactive CTG. We have again a normal baseline around 120 to 130. We have 2 or 3 or maybe 4 accelerations and no decelerations. The types of decelerations is as the following. We have the early deceleration, which presents a head compression. Early deceleration means the onset of the deceleration is the start with the onset of the contractions. You can see this. And the second type, the first one, the early deceleration, represents a head compression. The second type of deceleration is due to the umbilical cord compression. You can see as its name implies that it has no specific relation with the contraction. It can happen with contraction, it can happen without or in between the contractions. So it is a variable regarding the uterine activity. The third one, which is the most serious and the most one associated with poor outcome, is the late deceleration. It represents a uteroplacental insufficiency. Late deceleration means the onset of the deceleration starts after or at the end of the contraction or after the peak of the contraction. You can see that this is the onset of the deceleration, and this is the onset of uterine contraction. You can see that it started after the onset of contraction. The perinatal mortality in general is 6.2 per 1,000. False positive rates of the CTG is 50%. False negative rate is 3.2 in 1,000. Means if in the background of a reactive CTG, the likelihood of having an intrauterine hypoxia or fetus at risk of intrauterine hypoxia is only 3.2 in 1,000. But if the CTG presents some changes suggestive of hypoxia, we have only 50% chance for the baby to be in true hypoxia. So again, CTG is a good screening test, but it shouldn't be used as the sole way to evaluate the antenatal, risk of intrauterine hypoxia. Ultrasound, and one quick non-invasive procedure, easy to be interpreted. We have customized fetal growth charts. better to be used with serial scans, not single scan. This just to differentiate between the small progestational age, which is constitutional, and the small progestational age that is growth restricted. Um, Static growth being the same weight in two scans 2 to 3 weeks apart is considered as growth restriction. Crossing centiles on the growth chart is a sign of intrauterine growth restriction rather than constitutional. Constitutional, its weight is below the 10th centile, but its growth is doing well with each successive scan. Liker volume, always oligohydrogenous after rupture of membrane. The most common cause is growth restriction. Placental function can be assessed by Doppler study in the ultrasound, uterine artery Doppler, and umbilical artery Doppler mainly. Abnormal results correlate with increased risk of stillbirth and neonatal morbidity in selected pregnancies. So in high-risk pregnancies, we should do what is called the growth and well-being assessment for the baby. The baby is at risk of intrauterine growth restriction should be assessed starting from 24 to 26 weeks, should be assessed using growth and well-being assessment. Means we should do fetal biometry in each antenatal visit, not as the low-risk pregnancies in which we can just do the blood pressure, symphysis, fundal height, and urine dipstick. So the ultrasound is used, especially the growth scans, is used in the babies at risk of intrauterine growth restriction, that they are at risk of intrauterine hypoxia and stillbirth. Biophysical profile is um, five measurements collectively represent the fetal well-being. These are the fetal movement, the fetal tone, the fetal breathing movement, and amniotic fluid volume with the non-stress test. Each one has 2 points, either you have 2 or 0. Fetal breathing movement, at least one episode, بنشوفها على الchest during the ultrasound exam. We see a cross-section of the fetal chest. We see the breathing movement, at least one episode in 60 seconds takes 2 points. Fetal movement present at least 3 discrete episodes of movements. Fetal tone, the normal or position of the baby is the flexed position. So if the baby do just one episode of extension of extremities or spine with return to flexion, this is considered as a good fetal tone. Amniotic fluid volume, if normal, we can do it with the amniotic fluid index or the single deepest pocket. Normal amount takes 2 points in the calculations. So each one has 2 points, either 0 or 2. 10 is the upper, as we see. Highest score is 10, lowest is 0. Accuracy improved by increasing the number of variables assessed. Overall false negative rate is 0.6 per 1000. Again, it could be a good screening test, but I mean, if it is negative, that's okay, it represents a fetal well-being, but if it is positive, I mean it's abnormal, the risk of hypoxia is very variable. Sequence of events in hypoxia. First of all is the non-reactive CTG, absence of fetal breathing movement, reduction or loss of fetal movement, loss of fetal tone. We have some modifications on the biophysical profile. It's called the modified biophysical profile. It just have 2 uh, two aspects, the CTG and the amniotic fluid volume, and in some studies they said that the modified biophysical profile is comparable to the biophysical profile in its results. Doppler ultrasound is very specialized test. It should be done with a fetal medicine specialist. We have the umbilical artery, the middle cerebral artery, the ductus venosus, and in some cases the uterine artery. It should be used just in high-risk pregnancies. If we use in the low-risk pregnancies, it will increase the false positive rates and will increase the unnecessary interventions. So it solely used in high-risk pregnancies, and it can improve markedly the perinatal outcome in high-risk pregnancy. Thank you for your attention.